Good evening, everyone.
Hello. Hello.
Good evening, sir.
When do we start?
We'll start in a minute, sir.
Another?
In a minute, sir.
Sure.
Okay, sir. Could we start, sir?
Has everyone joined?
Like first two speakers has joined, sir, for the debate. We are waiting for other two faculty.
So perfect. So we can start right now. right?
Yes, sir. Yes, sir. So, a very good evening, everyone. On behalf of International Association for Integrated Oncology, I warmly welcome you all to today's Expert Insights session on lung cancer. This academic forum, together leading specialists from pathology, medical oncology, radiation oncology, and surgical oncology, to discuss how science and clinical expertise are transforming lung cancer today. Before we before we begin, it's my privilege to acknowledge our program director, Dr. Suman Gupta sir, Director, Metro Cancer Institute, Medical Director, Metro Heart Institute, and Senior Consultant and Head of Medical Oncology and Hematology from Metro Heart Institute with Multispeciality, Hyderabad. Sir, thank you for your leadership in shaping this excellent scientific agenda and for your continued support in advancing multidisciplinary oncology education. We are truly grateful. So, we begin with the welcome and context setting the stage for today's academic discussion. I would like to invite our program director, Dr. Suman Gupta, sir. Sir, over to you, please.
Thank you, ma'am. Thank you for this opportunity to be the program director for this session on lung cancer. So I think lung cancer is something which is close to heart of all medical oncologists, and with the evolution of the drugs, the genomics, and the immunotherapy in lung cancer, the total scenario has changed over the last few years. So I hope that today we have a very interactive and a fruitful discussion. We have some very interesting topics, and let us all get ready for a good scientific feast. Over to you, ma'am.
Thank you, sir. Thank you so much. So now we would like to welcome Dr. Vidya Aman ma'am, lead consultant, histopathologist from Manipal Hospital, Bangalore, to cover the topic constantly evolving role of pathologist in lung cancer management, in which pathology today plays a central role in precision oncology and biomarker driven care. Ma'am, over to you, please.
Thank you for the kind introduction, Roshni. First of all, thank you to IAIO for having me here for this session today. As we all know, it is World Cancer Day, and there's nothing better than lung cancer to be discussed here, as Dr. Suman Gupta also mentioned. And in fact, lung cancer has been the poster child for our precision medicine, driving all the way to targeted therapies. And there is a lot of evolution that is happening in terms of lung cancer. With this, I would want to share my screen. Let me know once you're able to see my screen, Rosh.
Okay, ma'am.
Yeah, you're able to see my screen?
Yes, ma'am.
Yeah. So the topic actually given to me today is the evolving role of pathologist in the diagnosis and treatment of lung cancer. So surgical pathology has vastly changed, and there is a two-way communication that is happening between the oncology teams with the pathologists, and it is more and more that the oncologists are actually coming into the lab scenario where they're trying to understand how the pathologists diagnose cases and how what type of tests are being done for accurate diagnosis. And since we're doing a lot of biomarkers, as I said, lung cancer is the poster child for precision medicine with the advent of markers like PD-L1, EGFR, AL, CROSS, etc. So it has far and far led the oncologists to the laboratory end also. And for us as surgical pathologists, it's becoming very imperative to offer an accurate diagnosis so that the treatment also happens properly for the patient. So my topic is actually clinical suspicion to precision medicine. As we know that the global lung cancer burden has increased, and more we are seeing this in non-smokers, and especially so in women. There has been a steady increase in the number of lung cancers that we are seeing, which is actually on the rise, though not as much as breast cancers and cervical cancers that we see, but it is definitely increasing. And not only that, there is an increase in the lung cancer cases. Most of these cases are now being diagnosed very early because here we are seeing various radiological modalities which have improved the early pickup of these lung cancers. And also patients are becoming aware due to a lot of these cancer awareness programs that happens on a regular basis in many of our hospitals. So as we see, since there is high mortality also associated, especially with these end-stage lung cancer cases, and we know that there are specific treatment and it is tailor-made treatment for most of our patients, it is becoming necessary for the pathologist to see whether we are going to put it in the exact bracket and whether we are able to histologically, morphologically subclassify these cancers so that further molecular tests can happen. If you look at the diagnostic algorithm, obviously we are looking at chest X-rays and very good CT scan, high resolution CT scans for pickup of these lung cancers. And that forms the major bulk of the radiology diagnosis along with PET scans. And then we come to the gold standard of diagnosis. I would say histopathology or your surgical pathology lab becomes a temple of truth because the clinician will definitely want to know, just a radiology image will not suffice for the clinician to know whether it is malignancy or a non-malignant case. So, because we see that lung is it's basically an organ which can host various other infections and inflammations. So it becomes necessary to differentiate and identify whether it is a cancerous or a benign lesion or an infective lesion. So tissue diagnosis plays a huge role here. And I would say we should actually call the surgical path lab as a temple of truth because this is where the diagnosis is going to happen. And with this, we are going to further collaborate it with our IHC findings and later molecular studies to see what treatment options can be provided for our patient. Obviously, from tissue diagnosis, whether it is non-small cell lung cancer or small cell lung carcinomas, we move on to our molecular profiling. And gone are the days where we were looking at just single genes or just one or two genes or even 10 to 12 genes. And now we are looking more and more at comprehensive gene profiling for our patients to better understand what are the kind of mutations that are going to happen. And obviously, in progression of disease, we are looking at various other steps to look at resistance also. And then comes in our multidisciplinary review to see whether the patient is eligible for chemotherapy or surgical excision has to be done for these patients. So this totally encompasses something from the clinical suspicion to confirmation to treatment and having an MDT review of our cases. If we look at the biopsy techniques, we do have various modalities. And for central and endobronchial lesions, it could be an EBUS TBNA guided biopsy along with the Rose technique also, which can be done here. And for peripheral nodules, we have the transthoracic needle aspirations and biopsies. Generally, transthoracic needle aspiration biopsies, the yield is high and we get good material, and these become the gold standard. And for inconclusive or small lesions or metastatectomies, etc., VATs can be done as a procedure. All this depends on once you have a review along with your radiologist as to what is the better technique for approach and guidance and for getting enough material. Here, material becomes very crucial because these are the days of triage, and we know that more and more the samples are becoming very tiny and small, and we have to very diligently sort out the tissue that comes into the pathology lab for adequate IHC and molecular tests. So when we look at the tissue preservation, so this is very, very important for the pathologist and the pathologist who's running the lab along with the other colleagues in the department as well as the technicians, because the standard checklist would be that we need enough tissue for our NGS test. And the standard tissue, what we mean is the volume of tissue that is there in our biopsies. The percentage of tumor volume becomes very important here, and at least 20% of tumor volume is necessary in these core biopsies. As and when the core biopsies are going to increase, what the pathologist does or how we are trained or how we are training people in the lab is that once the core biopsies are there, Generally, we do get multiple core biopsies. These are not put in a single cassette, and we are going to take them in multiple cassettes, at least 1 to 3 cassettes based on the number of cores. And we are going to assess them on the microscopic observation with our regular H&D slide. And based on which slide goes for, we are going to triage here which slide goes for IHC test and which tissue is going to go further for our NGS test. So the choice of fixative is 10% neutral buffered formalin, and this has to be reinforced, and people in the bronchoscopy units as well as in the IR have to be aware that the tissue specimen should immediately enter 10% neutral buffered formalin. Otherwise, there is chances that the tissue can get compromised and we may not land up with good molecular test results. And obviously, I mean, it is not very easy to tell that please do not give us areas of tissue necrosis. It is only a matter of chance here. And generally, in our reports, what we do is we elaborate on what is the percentage of tumor volume that is there in the core biopsies, along with the percentage of necrosis. And the tissues which have least necrosis are subject for our further molecular assays. Then ROSE is another test which is done, which is rapid onset evaluation, and we do it routinely at our center as well. So here the pathologist is going to confirm whether there is enough material or adequate material depending on the stage, on the stations of the lymph nodes that are going to be assessed here, or even for the adequacy of material. So this can be done as a rapid onset evaluation, at least to confirm the material. But generally, we do prefer the core biopsies. So what is it now, whether we want cytology sample or histology sample? There is no second thought on this, because many times the patient may present just with massive pleural effusion, and it may be difficult for you to do the core needle biopsies. So these times or these instances, we do take the pleural fluid for evaluation, and we are going to make cell blocks in this. And cell block preparations do have a good yield many times whenever the tumor volume is very high. And we are going to process these for our IHC studies as well. But cell block has its own problems. One thing is we may not always get the very good IHC stains, and we may land up with few false negative results also on our IHC. The other important question that we land up, and especially medical oncologists may sometimes tell us, do a PDL1 test on the cell block. Cell block is not the material of choice for our PDL1 test, especially so in case of metastasis when we are looking at a CPS score. But in lung, it definitely is not a problem for us, because it is going to be a tumor proportion score that we are going to see, and cell block material can be taken in these scenarios for the TPS scores. But as I said, the gold standard is still going to be our histology, and histology tissue is very, very important. And we need to, because here we have very good cellular architecture and we are able to further subcategorize what kind of cells these are. And the false negatives are going to be very less when compared to our cell block material. And the yield is also going to be very high. So the primary classification, once we have the tissue, very well fixed tissue, we have already made multiple cassettes, or the technician is also trained not to trim too much of our tissue and to preserve as much as tissue in the paraffin block as possible. And then we take few sections and see what is a morphology. Under morphology, the pathologist is going to diagnose whether it is going to be a non-small cell carcinoma or a small cell lung carcinoma. So in non-small cell carcinoma, it is going to be predominantly adenocarcinoma or squamous cell carcinoma, or we can have an unclassified pattern also. And then we have small cell carcinoma, where the treatment is going to go in an entirely different spectrum. So once we are going to diagnose an SCLC, it's obviously going to be an aggressive, very aggressive tumor with TP53 and RB1 mutations, whereas it is going to be a whole lot of other mutations which starts from EGFR and your other pathways of your AL, CROSS, MET, RET, etc. That is going to happen at the non-small cell lung carcinomas. Earlier, maybe we were able to do everything on morphology, but now we do take the help of immunohistochemistry. The next step is going to be IHC for subtyping. The pathologist is not always going to do IHC for lung carcinoma cases, because we know that the tissue is very, very important and precious. So we try to conserve more tissue for our molecular tests. So what do we do here? When in case of a doubt, like we're seeing solid pattern and we do not know whether it is a squamous or an adenocarcinoma, we try to take the help of what we call as TTF1 and P40. These are the two important markers which will help us differentiate whether it is an adeno or a squamous cell carcinoma. Many times we have burnt our fingers where we have tried to confidently call something as a squamous cell carcinoma with a very solid pattern, and then that has turned out to be an adenocarcinoma. Hence, these days we try to just classify it as an NSCLC and further subtyping by IHC. Two simple markers, TTF1, which is very, very confirmatory for adeno, and P40, which is very confirmatory and specific for squamous cell carcinomas. These two are sufficient. In case these two are negative, then we are going to add napsin A for our adenocarcinoma diagnosis. So these become important, and a CK5/6. Obviously, in lung, we also have the problem of mesothelioma also being, whether it could be a pleural base nodule, etc., and where mesothelioma comes as part of a differential. But we are going to take the help of morphology. And please remember, IHC is always an adjunct to our histomorphology picture. So if our histomorphology is very strong, then we are going to put very minimum markers on our IHC and then take it forward into other molecular testing patterns. The next is your small cell carcinomas or your neuroendocrine carcinomas, neuroendocrine tumors. So there we have carcinoids, which are typical carcinoids, atypical carcinoids, and you have your small cell carcinomas. So small cell carcinomas, we generally have specific markers, your synaptophysin, INSM1, which is new and a very specific marker for diagnosis of your small cell carcinomas. And we use the help of Ki67, which is a proliferative marker. Along with this, we use TTF1 to say that it is of lung origin. So nowadays, our NOS category is becoming very less thanks to the help of IHC. So IHC is going to help us further subclassify. In fact, more and more these days we're coming across adenocarcinomas which are becoming TTF1 negative. So we may land up with a case where we will have to add some more markers like CK7 and a few other things like your SAL4, your BRG1 or INI1 to land up and classify these tumors, telling that, okay, this may be SMARC associated tumors also. We are able to diagnose such tumors as well in the lab because of the advanced IHC test. Now, the moment we know that it is an adeno or squamous cell carcinoma, obviously the tissue is next taken up for a molecular testing. Now, NCCN guideline clearly recommends few important tests that have to be done. And first and foremost would be your PDL1, along with your, obviously, your driver mutations of EGFR. So here, lung cancer treatment is entirely driven by our EGFR markers. That is what we know. And along with this, we have a core panel which will encompass your ALK, ROS, BRAF, MET, BRAF, RET, NTRK, and your KRAS mutations. So ALK is something that we do on IHC as well. We have a particular clone called ALK D5F3, which is FDA approved and which is comparable with the gold standard of your reflex FISH test. We have ROS1 also. ROS1 still, it is a little problematic. I wouldn't say that we are all very happy with the ROS1 IHC that we do in the lab. So, but the gold standard and reliable diagnosis either would be your FISH test or would be your NGS method of testing. BRAF, etc., can be tested on your NGS tests. And also now we have one more recent marker, which is MET. MET IHC has also been recently launched, and many of our labs are still in the process of validating the test results. PDL1 obviously is an IHC test and it cannot be determined otherwise. Along with this, we have some emerging biomarkers. So these would be your HER2, your TROP2, and your Claudin. So all these are currently in various stages of trials, and TROP2 is something which is very new and latest to hit the market. I do not know how many of our like pathologists or medical oncologists are going to be in agreement on testing these in the lab currently, because this is something which is companion diagnostic in a true sense. This is one of the biomarkers which has been which has gotten FDA approval for the algorithm, artificial intelligence algorithm on which the scoring has to be done. So it is basically logged by a specific vendor where we do it on a specific platform with a specific clone. And these slides are then going to be digitized on a particular digital scanner of the company, and the algorithm has to be used for interpretation of this marker. So it is all the way up to the level of interpretation. It is locked as a companion diagnostic algorithm. So here in comes the problem. So these scores cannot be interpreted manually, and manual scores cannot be taken for the treatment purpose. So we are more and more entering the era of the digital pathology along with artificial intelligence algorithms that are available in few of our centers. And PDL1 IHC is also something where many of the labs currently may have already, especially the Western countries, have already started reporting the PDL1 scores out of these algorithms. HER2 is a controversial marker. As we saw last year, the previous 2 years, we have seen that HER2 and MMR have been tumor agnostic. Across all tumors, we are testing HER2. The same is the case with lung as well. But in lung, till last year, there was a bit of controversy. For other solid tumors, we were doing the HER2 IHC, but not so for lung. Lung, we were either doing the amplification, which is tested by FISH, or by mutation, which is tested by NGS. So we were not looking at expression, which is actually an IHC modality of testing. But there is some upcoming papers and research going on where we can look at HER2 expression by IHC even in lung cancers. So as you see, the other big question that comes is, do we do single gene panel or NGS? So comprehensive NGS is something that is being looked forward to and which is being done at most of our centers now, because gone are the days of single gene testing. It is like more the genes, more the information that we get, and better is going to be the treatment, because we will come across cases of progression of lung cancers wherein we need to know and go back and look at our NGS reports. And these days it is going into multi-gene panel testing, not so with our 12 or 14 gene panel, even that is gone now, even 50, 75. There are more and more advanced gene panels that have come up in the market where even 300, 400 genes are being tested. So maybe not now, but in future it can be used, and this is even going to be cost effective, as we have all seen that NGS test cost has come down drastically in the last few years. So we are looking at the comprehensive NGS panel rather than doing a single gene test. Now, why are we not actually happy with single gene test? Is you're going to exhaust your tissue. Like for example, today you're going to do an EGFR. Tomorrow, you know that EGFR mutations are not there. Then you have to do an ALK, then C for ROS, etc. You're going to exhaust the tissue, and we know that these tissues are precious. Hence, with one single test, like comprehensive NGS panel, you can try and finish these rather than just doing some single gene tests on a simple PCR or just small gene panels. It is no more the test. So what we do in the lab these days is we cut tissue for HND, IHC, which also includes your PDL1, which can be done. And then the remaining entire tissue is submitted for NGS test. That is a actual ideal scenario, rather than doing one test today, one test tomorrow. It will really not benefit the patient. It will only be harmful because you will have to again do a rebiopsy. Now, coming to PDL1 testing, this is one of the important tests which actually started with lung cancers. And we had initially problems with the clones, which clone to use, which platform to use, and how do we do. But now we are settled with the TPS, or your tumor proportion scoring, for lung cancer. And whereas other non-lung cancer, other than lung cancers, will go in for your CPS scores. So here for lung cancers, it is no more controversial. We have two good clones, which are 22C3 of DACO, and you have SP263 of Ventana. And these can be used interchangeably, and we no more have any problem. And here TPS is always given as a percentage, because we have the numerator and the denominator being similar, which is your tumor staining cells, and the denominator is viable tumor cells, and which are multiplied by 100 to give you a percentage. So a percentage of more than 50% score obviously is going to be eligible for monotherapy, and this is coming into a lot of testing prominence these days. So you need not have to worry on which clone. So both these clones are interchangeable. Next, we have CPS. This is for other than non-lung cancers. So here we are going to have the immune cells also coming into picture, where immune cells, the number of immune cells which are going to stain along with your tumor cells, and the denominator is going to be your total viable tumor cells, which is multiplied into 100, but this is never given as a percentage, because your numerator and your denominator are going to be different. And as I said, for lung cancers, you can use cell block tissues for interpretation of TPS. But if you're looking at, for example, a gastric carcinoma mets in the fluid, then obviously CPS cannot be given because we do not know what is a tumor microenvironment which is actually defined on tissue. The same cannot be defined on your cell block. As I've already discussed on these two emerging biomarkers, and HER2, I want to elaborate a little bit because here we are not only looking at drug resistance, we are also looking at recommendations by NCCN, which has clearly told that to do these HER2 mutation testing, especially when there is going to be brain metastasis and females and non-smokers. So where these are a poor prognostic indicators. And when you're ordering a HER2 test, you need to be very specific. If you're looking at expression, it is going to be IHC test. If you're looking at amplification, then it is going to be an ISH, either a FISH or a DISH test, which can be performed. And if you're looking at mutations, then do an NGS. So this is how the algorithm goes for your HER2 testing. Right now, we do not have any threshold definitions, unlike a gastric cancer or breast cancer, for the HER2 testing in the lung cancer. And we are definitely awaiting a few more papers and literature to be published on this. Now, when we have progression and when we are monitoring resistance, obviously it is going to be very, very important to do the liquid biopsy. So liquid biopsy is not really the first test of choice. First test of choice is always gold standard diagnosis on your histology or your biopsy. And if biopsy is not possible for the patient, then only liquid biopsy testing is going to be done, where we are going to test for the ctDNA and the cell-free DNAs. So this is an important test that is going to come up because you need to look at your resistance and especially your EGFR T790M mutations, which are detected on your liquid biopsies. And these days, more and more drug resistances are being tested by these liquid biopsy tests. So upfront, when you're doing the biopsy, you may try doing a liquid biopsy and see the threshold, and then like your MRD in hematology, how you're going to monitor, you can look at this in lung cancer also. But the main advantage is it is non-invasive and a biopsy situation does not arise for the patient. But as I said, this does not become the gold standard. Obviously, now the future is integrated. We are looking at integrating our pathology diagnosis along with radiology and genomics. So I would reiterate, tissue is the king because we need to conserve as much tissue as possible, because you need to have a report telling that it is a carcinoma and what type of lung carcinoma. And the same tissue is then subjected for your NGS test. Broad-based profiling is the method of choice going ahead and even now. So this comprehensive gene panels are something that needs to be done, and you need to have proper MDTs at your institute so that you have a multidisciplinary board meetings for looking at what is the best possible way of diagnosis. And these days we are also having our molecular tumor boards to see what kind of mutations, etc., and to discuss and have more awareness. And all this finally will lead to a dynamic monitoring. So what we are looking at is integrating the pathology data, the radiology data, and the genomics data so that we have very precise diagnosis being offered to our patients for their personalized therapy. So this is my last slide. I conclude by saying that what we are looking at is big data integration, and which is going to help us. And obviously pathology is coming up in a big way in offering you the exact diagnosis, and along with your AI being brought in very closely along with whatever the pathologist is seeing under the microscope. So way forward is good for the benefit of the patient, and definitely we should all look at a teamwork. So thank you very much. Over to you, Roshni.
Thank you so much, ma'am. Thank you for the presentation, ma'am. Thanks a lot. Ma'am, there is a question in the chat box. Could we be addressing the same?
Yes. Is it what's the question? One second.
Does the device used to score TROP2 to score specific biomarker, or it also scores for other biomarkers?
It is
This is
only
one of
for this biomarker. It's a very recent advancement, and I don't think any of us in India are currently doing it. So it's only for this particular biomarker. So all biomarkers will not have the same algorithm. Algorithms are designed on the kind of localization of the antibody that happens. So, for example, you have your for example, you have a nuclear stain, you have a cytoplasmic stain, and then you have a membranous stain. Like an algorithm for HER2 will be different from a algorithm from ER, and the same is the case with TROP2. So all these are specific individual algorithms, and they cannot be done one over the other.
Okay. Thank you, ma'am. There are a couple of other questions also. Should I read that?
Yeah, I'm able to read. Why shouldn't we do combined biopsy, solid and liquid biopsy? Because diagnosis will be much faster and respective treatment can be. See, liquid biopsy, I do not know. I would want some medical oncologist also coming into this question, because generally the procedure that anywhere that we start is, if you're able to get hold of the tissue, please get hold of it, because that is a gold standard, and there is going to be much more cell yield. And liquid biopsy, you may not already have the blood markers present at the time of diagnosis itself. That is more so in the advanced cases where you may not actually be able to perform the solid biopsy. So at that time, liquid biopsy is going to be helpful, but otherwise, I don't think you will actually need to do both in the same setting. And during
Thank
treatment
you, ma'am.
progression, then you will definitely require liquid biopsy.
Thank you so much, ma'am. Thank you for the presentation and responding to the queries which we had in the chat box also. Thanks a lot. Moving on to our next session. Now, I would like to invite Dr. Bala Stalan Chowdhury, Chief Medical Oncologist, Hemato-Oncologist, and BMT Physician, Mahatma Gandhi Cancer Hospital and Research Institute, Vishakhapatnam, Andhra Pradesh. Over to you, sir.
Yeah, thank you. So, is my screen visible?
Yes, sir. The screen is visible.
I am audible clearly.
Yeah. Yes, sir.
Thank you. Thank you, IAIO, for this opportunity. So, the topic I was given is the Indian experience with the immuno-oncology and targeted therapies in lung cancer. So a bit challenging topic. So almost I have done searched over the PubMed or the Google for the last 2 to 3 days and found a decent number of publications, around 20 to 25 publications on various targeted therapies and pembrolizumab. But what I realized after searching so long is still there need to be a lot of data which need to be published, because even after 5 years of usage of pembrolizumab, nivolumab, and other immunotherapy drugs in lung cancer, the publications of immunotherapy lung cancer is still limited, and possibly as a part of single center or a multi-institutional study. So we need to publish our real world experiences, what I felt at the end of searching all the articles. So coming with the background, so this is the one of the publication, a large publication from all the Tata Memorial Hospital, the clinical characteristics and first line palliative treatment options of more than 3,000 patients. And what this has told is, so the epidermal growth factor receptor and all positivity rates were lower in smokers, and most positive patients received the first line systemic therapy. But if you see, the tyrosine kinase inhibitors are given only two. So this is a period of almost between March 2000 2017, where the access to the targeted therapies were limited and immuno-oncology has not taken into the place. But during that period, so the tyrosine kinase inhibitors were given only to the half of the patients, 48% of the ALK patients and 54% of the mutation negative patients. So coming to the background of EGFR, so 2009 to 2020, multiple clinical trials, but majority of the times it is progression-free survival benefit, no benefit in OS because of high level of crossover. And all the trials had shown that the median progression-free survival is 9 to 13 months, and testing implementation becomes the key. This is the era where a first driver mutation was detected, and it had shown that giving it some form of targeted therapy in means of the first and second generation AG of tyrosine kinase inhibitors, they have significantly improved the progression-free survival. Because of the crossover, the overall survival benefit was not there. Thereafter, the second and third generation TKS came, the afatinib, dacomatinib are the second generation TKS, and slowly the third generation Flora came, which was the first tyrosine kinase inhibitor, which showed the overall survival benefit. Now we slowly moved on to the combination therapies, the combination of chemotherapy plus osimertinib in the FLARA-2 trial and the amivantamab plus lazertinib, another combination therapy in the second first line therapy. And these trials had shown a benefit of in terms of progression-free survival and has now become the standard of care for the EGFR mutated non-small cell lung carcinoma, and they had shown some amount of overall survival benefit. Also, the PFS benefit has translated into the OS advantage too. Coming to the Indian data on the EGFR mutated lung cancer, so over this 20 minutes of the talk, I will be dealing only the three common mutations because there is no much published data on the rarer mutations in lung cancer. So the three most common, the EGFR, ALK, ROS, and what was the data of the Indian patients on the experience of use of immunotherapy. Coming to the, this was my publication way back in 2015. I have published it in Indian Journal of Medical and Pediatric Oncology, IJMPO, where we have analyzed more than 300 cases of lung cancer. But then EGFR mutation was tested in only 134 patients, and which 47 were positive, accounting for 35% of the positivity. And the most common mutation was exon 19. Thereafter, in 2017, we have presented a poster in ESMO Asia. So, what happened? What is the difference between the smokers and non-smokers? So, it accounts for approximately, smokers tend to have very lesser number of mutations, like 24%, compared to 45% in the non-smokers. Whereas female non-smokers had a EGFR positivity of almost 57. That is almost 2 out of 3 patients are positive for the mutation. This is other study from Tata Memorial Hospital where they reported the incidence of 23% of EGFR mutation, and this is another study where it was reported to approximately 38. So there is a wide variety of data where the incidence of EGFR had shown to be approximately 30 to 35%. Coming to the survival, so this is the data from the Tata Memorial Hospital where so they analyzed the outcomes, and the progression-free survival of the patients with EGFR mutations was 10 months compared to the 2 months of EGFR. So the in and around. So this is the data where the first generation EGFR tyrosine kinase inhibitors were used, and this data as correlated, which was the progression-free survival, which was shown in all the EGFR mutation studies. And the overall survival was 19 months for the EGFR mutation positive patients compared to the 13 months with the EGFR mutation negative patients. And this is another study from RGCI. So this focused on the uncommon EGFR mutations. We all know that EGFR 19 and 21 are the most common, and they in this the uncommon mutations were tested of approximately 60% of the patients. 60 patients, and majority among the 12 patients who received the first line tyrosine kinase inhibitor, 7 received the afatinib with a median progression free survival of 8.13 months with an overall response rate of 57.1%. This is another study from Amrita, so where erlotinib and geftinib were used in non-small cell lung carcinoma patients where there is no significant difference between the two drugs. And the pharmacoeconomical analysis showed that geftinib was more cost effective than the erlotinib. So there is no survival difference between geftinib and erlotinib. And by and large, in majority of the centers, geftinib was the most common EGFR tyrosine kinase inhibitors which were used in the management of earlier days of the EGFR mutation positive lung cancer. And this study showed that both have similar effectiveness, with geftinib had better safety profile, also more cost effective. This is another study from Tata Memorial Hospital. The efficacy of geftinib in EGFR mutation. Does exon 19 deletion differ from the 21 deletion? So there was no much difference between the 19 and 21, but various trials have shown that 21 has a slightly poorer prognosis compared to the 19 mutation. But in this study, the response rates for exon 19 was 72.9% versus 55.6% for the exon 21, which is a significant, but median progression free survival was 9.3 months compared to 7.8 months, which was not significant. And the median overall survival was also numerically different, but it was not statistically different. So by and large, there were no differential outcomes in Indian patients of advanced non-small cell lung carcinoma with exon 19 and 21 who were treated with the geftinib. This is the another review article which was published by Dr. Bullas Batra et al. So where A classical differences between the 19 and 21 were identified. So exon 21 was more common in the male smokers. Higher exon 19 tend to have a higher serum carcinoembryogenic antigen, and age and end stage may be considered while predicting the EGFR mutation status, because NSCLC with exon 19 are associated with higher risk of pleural effusion, lymph node, brain, and bone metastasis. But when you are treating with a first generation tyrosine kinase inhibitor, Geftrin, the previous study had shown that there is no much difference in the progression-free survival and the overall survival. And whether the plasma testing correlates with the tissue testing for the EGFR mutation. So this was a study from Tata Memorial Hospital again. The plasma first approach for detecting. So this has a lesser turnaround time of only 3 days versus the 12-day TAT, and it had to be highly sensitive and specific. And using a plasma first strategy, given its shorter turnaround time, stronger positive concordance, and comparable outcomes to tissue biopsy, emerges as a highly specific and reliable method for detecting the EGFR mutation. So there is no significant difference in the clinical outcome of the patients whether they are treated based upon the liquid biopsy only or the tissue biopsy, around the progression-free survival of 11 months. Coming to the newer generation of tyrosine kinase inhibitors, there are no much publications on the data of osimertinib, but this is one data of safety of osimertinib in Indian patients from a phase 4 study in T790M. It found to be quite safe. The favorable safety profile, majority of adverse events are only grade 1 and grade 2 and very tolerable, and none of the serious adverse events and fatal events were considered as a study treatment related. This is another small study from Tata Memorial Hospital with the initial publication of osimertinib in T790M mutation study. So the median follow-up duration was 2.5 months, and 9 of 12 patients experienced a reduction in symptoms after starting with osimertinib, and 11 of the 13 patients had a radiological response evaluation. So these are all the existing studies which were published on the EGFR mutated non-small cell lung carcinoma. Coming to the ALK, we know that around 5 to 8% of the patients can have a ALK mutation, and the median overall survival has crossed around the 5 years, and now across the studies it is around 7 to 8 years. And these are all the trials, the recent trials of Alex, where alectinib was compared with the crizotinib, and brigatinib was compared with crizotinib in the Alta trial, and the Crown trial compared to the lorlatinib versus crizotinib, which shown that there is significant overall survival benefit with the second and third generation ALK tyrosine kinase inhibitors compared to the first gen, second generation ALK tyrosine. My data on the ALK translocation incidence. So this was a poster presented with ISMPWOCON way back in 2018, where out of the 281 patients who were tested for ALK translocation, 22 were tested positive, 7.8. Later, we presented this in the ESMO MAP Congress as 776 advanced NSCLC patients were tested, of which the incidence of ALK translocation tends to be 8.1%, and the ROS1 accounts for around 2.8%. If you see the outcomes, so the 1 year at a median follow-up of 14 months, the 1 year progression-free survival and overall survival were almost 71 and 75%, and the 2 and 3 year overall survival were 54 and 30%, and majority of the patients in this study were treated with the uh, crizotinib. And the 1 year progression-free survival and overall survival of ROS1 positive patients were the 75% and the 18%, and this is one of the largest study, and we have submitted it for the publication. Coming to the other studies of ALK positive non-small cell lung carcinoma in India, this is from Tata Memorial Hospital. So the majority of the patients received the crizotinib in this, and if you see the progression-free survival, the median progression-free survival was around 10 months. This is another study on ALK translocated NSCLC, the long-term outcome of crizotinib treated patients from Tata Memorial Hospital, and 188 patients were treated with crizotinib during this period of study with a median overall age of 50 years. And if you see, the median overall survival was 38.3 months. This is the largest study of ALK positive from India of ALK positive patients treated with the crizotinib. The median overall survival of 38.3 months, and the patients who received crizotinib in the first line has a median OS of 45.5 months as compared to 29.7 months for those who received in the subsequent lines. So this real world study confirms the long-term beneficial effects of crizotinib in all rearranged NSCLC with favorable side effect profile. So the most are transaminases, anemia, fatigue, and corrected QT, and well tolerated side effects, and like that which were registered in the study clinical trials. This is another study of second generation ALK tyrosine kinase inhibitors. So this is again from Tata Memorial Hospital. The safety and efficacy of alectinib in the first line treatment of ALK mutated and SCLC. So the total number of patients were 50, and if you see, the majority of the responses were partial responses, and the progression-free survival and overall survival was not reached, and expected 3-year progression-free survival was 69.3 months, and the overall survival was 85.7 months. And this is another trial from RGCA, a decade of treating all prearranged non-small cell lung carcinoma. So in this trial, so all the tyrosine kinase inhibitors were tried, the first generation, second generation, third generation, all. This is one of the largest cohort of publication of all prearranged tyrosine kinase inhibitors in from India. If you see the overall survival of all the cohort of patients, so if you see the 5-year overall survival is 44 months, and the 3-year overall survival was nearing 50%, and the progression PFS1 is highly significant compared to the PFS2. And coming to the OS by first line treatment class, if the patient is taking the third generation TK, so the overall survival was significantly better compared to taking the second generation and the first generation. And the similar applies to the progression-free survival also. So even the intracranial progression stratified by the first line treatment class was better for first generation, third generation TK compared to the first generation TK. And this was almost similar to what was shown in the newer trials of Alex trial and the Crown trial. This is the data of lorlatinib. So the use of lorlatinib in the treatment of again from RGCA. So where the the data of is limited across the TK generations, and if you see as the years passes on, so there was more accessibility to the third generation tyrosine kinase inhibitors. And if there is more access to the third generation tyrosine kinase inhibitors, ultimately the survival also seems to be better. And between the patients who were treated between 2018 and 2021, the median overall survival was not reached. Coming to this is another publication from India. So in the Journal of Global Oncology. So what is the economic evaluation of targeted therapies for ALK and ROS1 fusion positive non-small cell lung carcinoma? And this study made a detailed analysis of the economic evaluation and found that the prices of ceritinib and crizotinib need to be reduced significantly to make justify their value inclusion in the Indian publicly financed healthcare insurance scheme, because even though we have crossed around 7 to 8 years after the availability of the crizotinib, still 40 to 50% of the patients are not able to receive the ALK tyrosine kinase inhibitors, at least in the frontline therapy, because recently only the generics of crizotinib are available. And even though the generic forms of crizotinib are available, they are still costly for majority of the patients. Coming to the ROS1 fusion, so we know that 2 to 3% of the patients can have ROS1 fusions, and crizotinib and repotrectinib are the approved therapies for the treatment of ROS1 positive NSCLC. And this is the data on the incidence of ROS1 rearranged patients. So this is from the efficacy in the of crizotinib. So in this study, so the ROS1 rearrangement was seen in 2.28% of the patients, and the ROS1 rearrangement was present in 2.8% of the patients, and confirmed by the FISH. And objective response rate with the crizotinib was 64%. And at a median follow-up of 6 months, the study has not achieved the median progression-free survival and the overall survival. This is another publication from India, from Tata Memorial Hospital, where the ROS1 positive patients were tested, and in almost 68%. So, but only 50% of the patients are able to receive the frontline ROS1 tyrosine kinase inhibitor. Among them, only 20 to 30% are able to receive the frontline tyrosine kinase inhibitors, and remaining receive the in the later lines. And in those patients, so this is the overall survival. Approximately the 3-year overall survival was nearing around 50%. And those patients who received the TK in any line has a significantly better overall survival than the patients who doesn't receive the overall tyrosine kinase. Coming to the concept of immune checkpoint inhibitors, so we all know that for the patients with PDL1 more than 50%, single agent immunotherapy had shown significantly better survivals compared to the chemotherapy. And even the real world data reproduce the same outcomes which are seen in the randomized control trials. And higher PDL1 expression levels render more benefit as shown in the trials. This is the pooled analysis where TPS more than or equal to 80% showed a better overall survival compared to other studies. And these are the existing guidelines. And the immune checkpoint inhibitor versus chemo, these are all the studies which show that chemo immune checkpoint inhibitors for patients who is having any PD-L1 expression is significantly better than the chemotherapy alone, either in the squamous cell carcinomas or in the adenocarcinomas. Coming to the Indian data on these subset of patients, so this is a retrospective analysis of pembrolizumab with or without chemotherapy in advanced non-small cell lung carcinoma. So this is an experience from a tertiary care cancer center. So in this, the median progression-free survival was 10.2 months in the entire cohort, with patients receiving the combination therapy showed improved outcomes compared to the patients who received the monotherapy. That is 12.5% versus 7.8 months, and the overall response rate was also higher, 54% in the combination therapy compared to the monotherapy. And this data suggested that pembrolizumab with or without chemotherapy is an effective and safe treatment option for the advanced non-small cell lung carcinoma in the Indian patients. This is another study from RGCA, the immunotherapy in advanced non-small cell lung carcinoma. So this study had shown that the median follow overall survival and progression-free survival was around 36 months, 7.1 months, and 3.2 months, respectively. For chemotherapy study looked at pembrolizumab in trials of melanoma and non-small cell lung carcinoma in India, and the results of this study were published in an international conference. And in this study, so there were some amount of non-small cell lung carcinoma patients. So 32 patients of non-small cell lung carcinoma were there with a median age of 64.5%, and this is mainly to assess the safety. And it had shown that pembrolizumab is quite safer in Indian population too. And this is another study from RGCA, the first line pembrolizumab for metastatic NSCLC in lower middle income countries, bridging the efficacy effectiveness gap. And this study was done for a period of over a period of 5 years from 2019 to 24. And with a median follow-up of 27 months, the median overall survival was 21 months and the progression-free survival was 6.3 months. And this real-world data demonstrated comparable effectiveness of pembrolizumab-based therapy in advanced NSCLC despite a higher proportion of adverse events. And those patients who have a TPS of PDL1 more than 50% significantly lowered progression and mortality risk. And the conditional survival probability for an additional 6 months after surviving the first 6 months was approximately 78.1%. This is another study from Tata Memorial Hospital of a real world data of immune checkpoint inhibitors. So this is across all solid tumors, and this shown that the pembrolizumab is efficacious in Indian population while retaining its effectiveness and quite safe. So these are all the studies which were published on targeted therapies and immunotherapy drugs in the advanced non-small cell lung carcinoma from India. And by and large, majority of the trials had shown equal survivals what was demonstrated in the trial, but the access to these drugs in the real world is quite limited because of the cost of the drugs. But some support program has made more accessibility, but still 50 to 60% of the patients may not be able to procure these drugs in the real world. So Indian lung cancer patients present predominantly with advanced disease, with adenocarcinoma being the most common and high prevalence of actionable driver mutations, especially EGFR, particularly among non-smokers. And EGFR TKS remain the backbone for these therapies, demonstrating superior progression-free survival, overall survival, which was shown in the clinical trials. But Indian real-world data confirm that EGFR mutated in ALK patients derive substantial benefit from targeted therapies, with outcomes comparable with global trials when access and testing are optimized. So to conclude, the future of lung cancer care in India lies in timely molecular diagnosis, rational sequencing of targeted therapies, and most importantly, equitable access to the precision oncology. Thank you.
Thank you so much, sir. There is one query in chat box. Could we address the same now, if possible? Sorry, sir, you're on mute. We are unable to hear you.
What is the
Yeah.
prognosis in case of multiple mutations in comprehensive NGS, especially L858R? That one? Is that the question?
The NSCLC EGFR mutation patient having mets, mostly brain and bone, have good OS when given combination therapy. If they have good OS, then will they have progressed disease or partial response or stable disease? This is the query which is received, sir.
So by and large, if I talk about the site of metastasis and the overall survival and the progression-free survival, so brain metastasis and liver metastasis are the two sites where if they are present at the diagnosis, so there is it amounts to the significantly poorer survival compared to other sites of disease. Second thing, So those metastasis across all trials had shown to have worse prognosis, and the combination therapy, especially in the recent FLORA-2 trial, had shown that. So the use of combination therapy significantly improved the survivals even in patients with brain metastasis.
Okay, sir, there is one more query which came from Dr. Abhishek right now. With Nivo biosimilar in India, do you consider it as a neoadjuvant therapy for resectable NSCLC as in CM816?
Possibly, yes.
Okay. Yeah. Thank you so much, sir. Thank you for the very informative presentation. We
Thank you.
now move on to our next session, which is a debate on the topic the role of radiation oncologist is over in early lung cancer in today's era. To speak for the motion, I would like to invite Dr. Sanjeev Kumar Mishra, Director and Senior Consultant Radiation Oncology, Utkal Hospital, Bhubaneswar. Over to you, sir.
Yeah, am I audible? Hello, am I audible?
Yes, sir, you're audible.
Okay, please share the screen. You have the PPT, no? So my video is not working. You can share the screen.
No, no issues, sir.
Yes, Anita?
One second, sir. The team is sharing the PPT, sir.
Okay,
Just a moment.
no problem.
Yeah, yeah, they have shared, yes.
So whatever the debate was in favor of telling in favor of radiation, somebody told radiation job is over probably. Yes, we have molecular now many of the new molecules that have come, and also the molecular study has given a very big role in treatment of lung cancer, but mostly in metastatic setting, not in early stage. Early stage. So in early stage, if you see, you can change the slide from your side. Yeah. So we will find here the role of radiotherapy in early lung cancer. Uh, See, definitely is still an opinion, an option because early stage lung cancer mostly treated by surgery. So most of the time the patients are all of elderly age group, and in an elderly age group patient having comorbidity like somebody is a smoker having COPD, somebody having cardiac comorbidity. So with all these morbidities and all, majority of the patients are not fit for surgery. So that is why a local therapy option is the only option is a radiotherapy. Next slide, please. Yeah. So there are clinical trials in favor of radiation, but none of the trials, like in some of the big trials, the equal was not finished, not complete, because all the alone the patients are going to come from the surgeons. So there are few of the early work by Timmerman et al. And he has shown a 95% at 2 years excellent local control. So with that, actually, it was a phase one, phase two study. They tried SBRT, stereotactic body radiotherapy, in a long back with a very high dose, around 60 gray in 5 fraction or 3 fraction like that. They thought probably this will be like work like a radiosurgery in brain. The same principle they applied here in the lung, though it is a mobile target or mobile organ with respiration. In spite of that, also taking a gated technique and taking a DIVS technique, they tried to concentrate the dose over the tumor, and in a phase 1, phase 2 trial, they found that yes, there is a response rate or a local control around 95% at 2 years, and toxicities are minimal, not that much. Next slide, please. So, a randomized trial, when they try to do, especially in an operable patient, again the patients are coming from the surgeon. So, obviously, the surgeon will try to operate the patient unless there is a contraindication for surgery, like those who are having comorbid. That is why when they operable patient, when they tried to give radiotherapy, they did not get much number of the patient, because what happened was like uh, the accrual was really very poor. To get a statistical significant early stage, such early stage lung cancer numbers are less. And to get a statistical significance, again, you need more number of patients. And accrual is poor because the patients are coming not directly to the radiation oncologist, coming from the surgeon. So they got those patients those who are not fit for surgery. So that is the two trials they've tried, like Roselle and a STAR trial. Both the trials aim to randomize operable stage 1 non-small cell lung cancer patient to SBRT versus lobectomy. So those patients who are fit for lobectomy, the surgeon is to operate. So that is why for fit patient or good patient, good general condition patient, we did not get for radiotherapy. So those patients are coming for radiation, those who are not fit for surgery with a poor general condition, with a comorbidity associated with the not fit for a surgical, not a surgical candidate. But with that also, there are 50 patients, 58 patients in early data. If you see, there are 58 patients. 3-year overall survival is numerically higher with SBRT, like 95% versus 79%. So the SBRT arm was still having good overall survival of 95% versus the non-SBRT or the surgical arm, the OS was 79%. Though the sample size is low and it was not clinically statistically significant. That is why, though it was a trial in favor of SBRT, but it was not statistically significant. Next slide, please. Another two trials, say RTOG 1021 and SGOG Z4009. It is again a randomized trial, SBRT versus sublobar resection in high risk operable patients. Closed early because of insufficient accrual. No definitive results are not available. Despite closure, these efforts show a difficulty of randomized trial comparing SBRT with surgery, because the patient and the physician often have a strong preference. So obviously, if you give preference to the surgeon, to the patient, that yes, this patient is going to get cured with surgery, maybe you can remove in toto. On the other hand, the radiation oncologist is going to tell that no, no, probably it is comparable with surgery. I will try to give radiation and control it locally. So unless the patient is not fit for surgery, he is not going to come for radiotherapy. Next slide. So other than that, there are few ongoing trials or later phase randomized trials. These are the larger trials are expected to provide more definitive evidence. Valor trials or NCT 761. These are randomized trial. Probably it is going to, the result is going to come this year. M was to enroll 670 number of patients. The other trial was StableMed trial. Again, compare SBRT with sublobar resection in operable patients. We focus on 3-year overall survival. SBRT tooth UK trial, another randomized comparison of SBRT versus surgery in stage 1 small cell and non-small cell lung cancer. The aim is to form an equivalence or superiority in overall survival and quality of life. Next slide, please. Next, please. So there are a few other trials also, like this Lustra trial and the meta-analysis of the real-world data also, and as such series you will get lot of series, lot many series, but again you need a comparative result with the surgery, like surgery versus SBRT, lobectomy versus SBRT, or a like a minimal resection versus SBRT. So these are the things. So though the surgical lobectomy often show a better observation in large population study, but likely influenced by the patient selection and the comorbidity. Because see, most of the time the same patient who is going for surgery is a fit patient. So that's why when you look into overall survival, you cannot tell that you are taking one arm those who are with comorbidity, another arm or those who are not with comorbidity, and you are going to compare. It is expected that surgical arm will be superior, but in spite of that, also few series in the beginning they show that probably there is a advantage of SBRT over surgery also. Multiple observational cohorts and meta-analysis show a excellent local control and low toxicity with SBRT in medically inoperable early cases. If you look at toxicity, actually, see, surgical, after all, it is an invasive process. But SBRT is a non-invasive process. The quality of life after radiotherapy is very good. It is nowhere the surgery is comparable with SBRT. Now, question is a local control or a disease-free survival or a overall survival. So it is, if it is comparable, then it's okay, fine. Probably we can go for a radiation, but we don't have a randomized data. Next, please. So to conclude in these trials, like SBRT is standard of for medically inoperable early stage non-small cell lung cancer, excellent local control and relatively low toxicity. The randomized evidence versus surgery is limited because you cannot because you cannot compare both the arms. You are not going to get patients for a limited number of patients for having a statistical significance. But again, the Lustra trial add prospective data comparing SBRT to conventional RT, though the evidence is more in favor of SBRT. And SBRT gives like few fraction, maybe 3 fraction or 5 fraction treatment, non-invasive, OPD basis treatment, and it is going to get cured. Definitely the quality of life is much better. So large randomized trial, all these trials what I was discussing like Valor and the SBRT2 trial. Probably these results, when it will come, probably it is going to give us a better idea. Maybe it might become a standard of care in early cases without surgery. So that is what my thing is. I think we should. It is a myth that the job of radiation oncology in lung cancer is gone. It's definitely a myth. Thank you.
Thank you, sir. Now, I would like to invite Dr. Neha Gupta to speak against the motion. Dr. Neha Gupta is a consultant medical oncologist and hemato-oncologist from Max Healthcare, Punjab. Over to you, ma'am.
Thank you. First of all, I will thank you, IAIO and Dr. Suman Gupta sir for giving me this opportunity to speak on this current topic that role of radiation oncologist is over in treatment of early stage lung cancer. Can I share my screen, please?
Yes, ma'am, please.
Is my screen visible?
Yes, ma'am, the screen is visible.
So, as I has told that there's a myth of radiation oncologist role is not over in early stage lung cancer, I will like to say against this because as we all know that now the early stage lung cancer is not a local disease, it is a systemic disease. For this systemic disease, we need both surgery as well as systemic treatment, which will help in controlling the disease in a good way. First of all, we will be discussing about the historical paradigm. that is pre-SBRT era, in which surgery has become the gold standard, was the gold standard, and now also is the gold standard for operable early stage NACLC. This data came from the Ginsburg et al., which was published in NHGM 1995, in which they have told that lobectomy is the gold standard for operable early stage lung cancer because of good overall survival and because of less recurrence rates. Then came the era of conventional RT, where if the patient is not operable because of if the patient is not willing or medically inoperable reasons, patient were offered conventional RT, but outcome with conventional RT was very inferior with a poor local control and with 5-year overall survival of less than 30%. So RT never competed with the surgery in operable disease. In next coming to SBRT era, when the RT from the conventional RT, we moved to SBRT era, in which there also many studies came like RTOG 0236, in which they were all they were suggesting a very good local control of 93%, but a poor 5-year OS of 40%. But here's a limitation. We don't want only local control. We want a systemic control as well. So local control is not equal to survival. The second limitation of the study was because of the SBRT, we cannot provide proper accurate nodal staging, which was a fallacy in this particular trial. And the next is because of not accurate nodal staging, we cannot offer a proper adjuvant treatment to the patients. So there was no systemic disease control. So SBRT has replaced conventional RT, but not surgery. Then many trials have came into action which were comparing surgery versus SBRT. There were real world and registry evidence large population based studies in which they have shown that lobectomy was superior to SBRT for overall survival. SBRT was only comparable to sublobar resections, not the lobectomy, which is the standard of care. And also because SBRT missed the occult nodal disease in 20 to 20% cases because of inaccurate nodal staging. So SBRT was never equivalent to surgery, that was lobectomy, which is the standard of care now also. Now, yes, then another study came which was head-to-head comparison of SBRT versus surgery in operable early stage lung cancer. Stars and Roswell study came, which was a pooled analysis which was published in Lancet Oncology in 2015. They were suggesting that it has a good OS advantage with SBRT over surgery. But how can you make a conclusion from a very small sample size from just 58 patients, because of which trial closed early and because of less number of patients, less sample size, it was statistically underpowered. And because of which wide confidence intervals was there despite significant p-value, but because of which false inference was made from the study. And the next point was there was inferior nodal staging which was done in SABR arm as compared to lobectomy arm. And then not all SABR patients were having tissue diagnosis, because of which a false inference was made that it was having a good OS over surgery. So it is a hypothesis generating study only. It is not a practice changing study. So still now we are with surgery, that is lobectomy in early stage lung cancer. Then another thing which is always said that SBRT has a low morbidity, which is always said by the radiation oncologist people. But now we have shifted from open surgery to VATS or robotic surgery, which have reduced periop morbidity to the tune of less than 1% in a good experienced centers. So this is also a good thing. We can offer the surgery to a fit patient, and also age is not a criteria for selecting the patients for surgery or RT. Then many trials came like LGB and JCOG trial, in which they have compared sublobar section segmentectomy, which was non-inferior to lobectomy. It was basically in the selected patients only, like the patient having tumor size of less than 2 centimeter or in peripheral location, or the patient having poor pulmonary reserve. This surgery was offered to those patients. These studies also have said that it is having good overall survival. So at the end, surgery became less invasive yet oncologically superior. Then came the era of systemic therapy revolution, which has changed the whole notion that surgery, because systemic therapy revolution came because of surgery only, because we are revolving around surgery only. So RT was to control local disease only. We have a modern therapy which targets micromets as well. We have so many trials coming into action from 2020, starting from 2020, we have a DORA trial in which adjuvant awesome, in which we are all offering in EGFR mutant resected NACLC from stage 1B onwards. We are offering osimertinib to patients at least for 3 years or until recurrence. we can see clearly that a good 5-year DFS rate to the tune of 65%, 2-year DFS rate to the tune of 90%, there was marked reduction in the recurrence of CNS mets and a good overall survival. So adjuvant osimertinib became the standard of care in resected lung cancer patients. Then came Checkmate 816 trial in 2022, which have changed the new adjuvant era also. In this new adjuvant, nivolumab was combined with the chemotherapy, followed by surgery, in which we can clearly see that there is a good major pathological response and good EFS, that is 31.6 months versus 20.8 months. So it has also become the standard of care for operable stage 1B to 3A patients. Then now we have a Keynote 671 trial in which peri-op immunotherapy is being offered, in which we can clearly see that a good event-free survival to the tune of 62.4% and a good PCR rate, 18.1%. So early stage NSCLC is no longer a local disease. It has become a systemic disease. And now the latest trial, New Adora trial, in which we can see in the EGFR mutant NSCLC patients, we can offer new adjuvant osimertinib plus chemo or osimertinib alone. By adding osimertinib, we can clearly see we have achieved a good PCR and a good major pathological response, because of which we can get a good overall survival rates in the future. So, Neodora confirms that in EGFR mutant early stage NSCLC, cure is driven by peri-op targeted therapy rather than local radiation, so further eroding the role of radiotherapy in the operable disease. Then current guidelines also suggest that surgery is equal to preferred curative treatment. SBRT is only for medically inoperable patients, not for the operable patients. And finally, concluding my slide with, early stage lung cancer has evolved from a local disease to a surgical systemic disease, and radiotherapy has lost its curative dominance not due to failure but due to superior alternative. Thank you.
Thank you, Dr. Neha Gupta, ma'am. I would like to thank both Dr. Neha Gupta, madam, and Dr. Sanjeev Kumar Mishra, sir, for sharing your views on radiation oncologist is over in early lung cancer topic in today's era. So, moving on to our next session. Now, I would like to invite Dr. Sunil Jaiswal, Senior Consultant, Surgical Oncology, Bhubaneswar, to talk on the robotics perspective on the topic robotics versus VATS. Over to you, sir. I suppose sir is having some network issues. We are connecting with sir to rejoin. In the meanwhile, I request the permission from. Hello? Yeah. In the meanwhile, I request permission from Dr. Suman Gupta, sir, to start the. If you could start the session with the next topic.
Hello.
Sir, can we start our the talk session until Doctor joins for the debate session? Sir, I'm so sorry, Dr. Sunil Jaiswal, sir is like yet to join. We are reaching out to him regarding the same. With your permission, can we move on to the talk session? Then can we cut back to the debate, sir?
Yes, please go ahead.
Yeah, thank you so much. I would like to welcome Dr. Abhishek Tiwari, consultant medical and hemato-oncologist, Regency Hospital, Kanpur, Uttar Pradesh, for the talk on future of metastatic lung cancer and role of CAR T cell and evolving therapies. Over to you, sir.
Just a second, please. Are my slides visible, please?
Yes, sir, it is visible.
Okay. In the day of the World Cancer Day, I have been allotted a humongous topic, and I would like to thank the organizer, the IAOI team, and obviously the Suman sir for providing me this platform. So to start with, my topic of discussion is the future of the metastatic C lung and the evolving therapies into it. And this is a humongous topic, and we will probably discuss only about the non-small cell part in this discussion, small cell part, and probably a targeted part is left to some other discussion. So in this discussion, we talk about what happens and what are the new therapies which we have in play right now, in development right now, after immune therapy has failed. So what are things which are undergoing? So I think to start with, I would like to discuss about the resistance mechanism as well. So we have resistance mechanisms which are developed inside tumor cells after we have exposed them towards an immunotherapy, a chemotherapy, etc. So these may be divided into intrinsic mechanisms as well as extrinsic mechanisms. Intrinsic mechanisms, the ones which are present already in the tumor cells. So we have some gene mutations such as STK11 and KEP1. STK11 and KEP1 are known gene mutations, and probably it is advised to start a dual combination immune therapy into it. Probably we have to start with a Nivo and EP upfront as well. Presence of these mutations are usually associated with a poor response to a single agent immunotherapy, even if a PDL1 is more than 50%. While on the right side, as we can see here, we have extrinsic mechanisms. We'll discuss about these extrinsic mechanisms probably in the next slides. So after these mechanisms, what are the ways to improve the immunotherapy? So I think the first ways to improve the immunotherapy is to increase the function of T cells and then to improve the tumor environment as such. How to do it? We have variety of novel ICI combinations and therapies. We have anti-CTLA4, we have CTLA4 with VEGF, we have anti-lag antibodies, and on the other hand, we have a bispecifics. So in the case of bispecifics, we have variety of combinations, which some of these which we are already in use, such as amivantamab, which is an EGFR and MET inhibitor, and probably such combinations we will get discuss what are in the picture. The third mechanism is to use cellular therapies. So probably a CAR T cell therapy may work. Probably we can have the use of a TILs. And the fourth mechanism of action is to increase the immunogenicity of the tumor itself. So we can develop the vaccines also. So we will look all these in the upcoming slides. So summarizing all these therapies in one slide, we have this slide in picture. On the left-hand side, if we start, we have immune checkpoint inhibitors. So all the immune checkpoint inhibitors other than a PD1 and PDL1, which are being checked into the trials are here. So we have LAG3, TIM, CD73, NK, G2A, and CCR8. All these therapies, all these drugs are being targeting these molecules are in work right now. Then we have bispecifics, in which we can use a dual checkpoint inhibitors. We have immune checkpoint and angiogenesis combined together. We have BiTEs upcoming as well. Other than that, we have ADCs. Some ADCs are already in picture about of HER2, but other unique molecules which do target some cells which include a TROP2 inhibitor, a B7-H3 molecules are in picture as well. Then finally, we have a novel molecules in the form of mRNA vaccine, peptide vaccines, and CAR T cell therapies as well. So we'll first discuss about the immune checkpoint inhibitors and bispecifics, and then we will move on to the other therapies. So our first mechanism of action is to use a bispecific which has two immune modulatory for the price of one. So probably we have already used it in some case or the other. We have used Nivo and EP, in which we have CTLA4 blocking. Along with that, we have blocking of a PD-1 receptor. So why not combine these two therapies into one to produce a single molecule which is as efficacious or probably even more efficacious? So this mechanism, this hypothesis is in development of all these drugs. So probably if we look at the immune synapse here, we find that other than a PD-1 and PD-L1, we have other molecules in downstream stimulatory pathway as well. So we have already explored about CTLA4. So we have been using CTLA4 along with PD-1 and blockage. We have also used LAG3 molecules, especially in melanoma. We have relatlimab, but other molecules may also be targeted. So we have TIM3, anti-TIGITs, BTLA, and TROP2. All these drugs may be targeted as well. And just a second. Yeah. So we have other molecules to target as well. Now, in this phase, we have the first molecule, that is volrustomig. Volrustomig is a bispecific which has a unique mechanism of action. It has anti-PD-L1 and CTLA rolled into one molecule. So this has been explored in the variety of trials. The first trial which we looked here, it used the drug in the dose of around 1500 mg along with the chemotherapy, and they found a substantial response into it. And if you look at this trial, we find that this drug has benefited across all the populations, across the squamous population, across the non-squamous population. It has worked in the PD-L1 subgroups of less than 1% as well as more than 1%. And it has substantial response lasting up to around 18 months or more. So it is irrespective of histology, and it works irrespective of a PD-L1 status. So that makes it an interesting drug. And so as of now, we have a variety of trials, especially phase 3 trials was as well ongoing for volrustomig. Other drugs are also in the picture, and enfortumab is also being explored. Cadonilimab is also being explored. Most of the drugs are in the phase 2 or phase 3 trials. We probably have the results soon. The second mechanism of action is LAG3 inhibition. So LAG3, as we have known from the melanoma, is one of the drugs which is co-stimulatory and present in the T cell. It competes with a TCR receptor for the antigen. And if we inhibit the LAG3, it will be a good mechanism to stop the immune evasion. So LAG3 molecules are already, as we have discussed, being tested and approved in the melanoma. On this rationale itself, we have used nivolumab, along with that relatlimab in the dose of 360 mg every 3 weekly, along with the backbone of a chemotherapy in this Relativity 104 trial. But if we look at the response rate, we find here the response rate is not very good. The difference in the overall response rate is just 7.6%, and the progression-free survival hazard ratio is 0.88 only. But if you look at the subgroup analysis, we find that all low, and behold, we have the response rate if the PD-L1 is more than 1%. So in this particular subgroup, we find that there is substantial response rate. The difference in the overall response rate is around 18.4%. The median progression-free survival has almost doubled now, and the hazard ratio is 0.55. So if you talk about anti-LAG therapies in the CA lung, probably we will look forward in the subgroup of the population with PD-L1 more than 1% only. And then we have second drug in this case, that is FT. So FT Lakimort is combined with pembrolizumab for 8 cycles along with pembrolizumab for 1 year. We find that it also has substantial benefit. The median overall survival in this trial was around 20.2 months. And it was even more if the TPS score was higher. And FT is a soluble lactate protein, and it does target an MSC class 2 molecule to mediate the APCs to the CD8 activations. And the third drug, which is in picture, is TOBI. So TOBI is then again combined with a CT backbone, and then it is for 4 cycles, and then it is we have a maintenance as well. We can do a single maintenance, or we can do a PEM maintenance as well. But unfortunately, this drug has been discontinued by Merck. Probably some other group can take this drug in the future. So if we talk about LAG3, probably we have only 2 drugs in picture right now, relatimab and FT. Along with that, we have fianlimab as well. So fianlimab is also being tested in the phase 2-3 trials. We do not have phase 2 data right now. And we now come to our third mechanism of action, unique mechanism of action, that is an anti-PD-L1 and anti-TIGIT antibody. So so if we look at this slide, we find that the mechanism of action of the TIGIT molecule, we find that in the NK cells, if they have to immunologically act towards a tumor cells, CD2 to 6 should bind with CD115. But if we have a competing TIGIT molecule, it does bind with the CD115 itself, thus causing an immune evasion. So this immune evasion, which does results into the immune suppression, and probably blocking this mechanism and action will lead to the response and reactivation of the immunity. Among all the drugs which has been tested in this regard, rilvegostomig is probably the most active, at least in vitro. It is the most active drug, and it is probably developed by AstraZeneca right now. Other drugs which are in the picture are developed by Roche, and Skyscraper trial is ongoing. Skyscraper 1 and 2 for tiragolumab is ongoing. MSDs also have few trials in the pipeline. KeyVibe 003 and KeyVibe 007 for vibostolimab is ongoing, and other trials are also going for some other drugs as well. But most of these drugs, other than Skyscraper 01, are being discontinued for the futility. So the future of anti-TIGIT mostly lies with the Artemide trial, and probably we will have this drug going on in the future, because as we can see here, the response rate with Artemide trial is superior. The progression-free survival is as high as 27.2% in the CPI naive patient. And if we look at in this analysis in the Artemide 1, we find that the overall response rate is as high as 62%. The median progression-free survival reported is around 12.3%. In comparison, in the control arm, we have half the survival. So AstraZeneca probably will develop this drug in the future. Probably in the phase 2 and 3 trials are ongoing for this drug. For the other drugs in the picture, probably the things are not looking as good. So we do come to our fifth mechanism of action, that is a PD-L1. Along with that, the drug also have anti-4-1BB action. So this is especially useful in the IO resistance, and the drug is acalabrutinib. Acalabrutinib in the dose of 100 mg every 3 weekly for 1 or 2 cycles. Then we increase the dose to around 500 mg for every 6 weekly, and the treatment is continued till progression. So we have been using it as a single therapy, or we have combined it with a pembrolizumab, either 3 weekly or 6 weekly. We find that this trial was beneficial, and this phase 2 trial was beneficial. And now we have another trial in picture as well, that is the ability trial. And the ability trial, we have combined acalabrutinib with pembrolizumab for 400 mg every 6 weekly. and other drugs are also ongoing. So acalabrutinib is one of the drugs which is undergoing development and trials in the Western world. But if you look at the Chinese market, we find that variety of drugs are being also developed there. So around 8 to 10 drugs are being in the pipeline from the China itself. Then again, we have our sixth mechanism of action, that is VEGF blocking. VEGF blocking, as we have already discussed, that it is an immune suppression mechanism, and probably to suppress VEGF is a promising concept. But our hopes have fell short because we have used these VEGF blocking with probably a TKI. So we have the regimen such as ABCP, which has moderate benefit, but other trials such as a LEAP trial, which we have combined lenvatinib along with immunotherapy, or cabozantinib, have had negative results as of now. But what happens if we combine a VEGF and PDL1 using a bispecifics in a single molecule rather than having a different molecules altogether? So 4 drugs have to be kept in mind if we talk about anti-VEGF and anti-PDL1 combination. The first drug is obviously ivonescimab. Ivonescimab is being developed by Akeso along with I think Roche is being developed globally. Other drug which is in the picture is BNT327, which is called as pumitamig, which is developed again in the Western world as well. And most of the other drugs are being developed in China. So we look at this drug, ivonescimab. It is undergoing variety of phase 3 trials right now. Pumitamig is also undergoing phase 3 trials by the BMS in combination with a Chinese drug pharmaceuticals. So one of the favorite trials to discuss here is Harmony 2 trials, and with ivonescimab was compared with the pembrolizumab in the PD-L1 positive advance in SCLC, and we find that this was substantially beneficial in the terms of progression-free survival, but this trial was not powered to look for overall survival. So probably we required new trials to look into the overall survival benefit. And for that, we have Harmony 6 trial. Harmony 6 trial is another important trial in which we took this ivonescimab 20 mg per kg 3 weekly combined with the chemotherapy backbone for 4 cycles, and it was compared with tislelizumab and CT backbone. CT backbone and tislelizumab itself is a strong comparator arm, and this was the first trial which was done in a squamous cell population. So we have this dogma that anti-VEGF will not work in a squamous cell population, but this trial shattered that dogma. Right now, as we can see here on the right side on the graph, we find that the median progression-free survival is around 11.14 months in comparison to the tislelizumab, which is around 6.9 months itself. The hazard ratio is 0.60, and this challenges the dogma that squamous cell lung cancer VEGF inhibition is not good, as it is shown in this trial that is safe and efficacious, while the Harmony 3 trial, which is a global trial, is awaiting the result. Probably ivonescimab we will see in the future much more. And then we have the second drug, that is pumitamig, which is undergoing development in the phase 1-2 trials. It has shown superior response in terms of partial response in this phase 1-2 trial. Other trials are also undergoing. Then we have this third drug, that is SSG 707. If you look at this trial, we find that the response rate is pretty high. The overall response rate in the dose of 10 mg per kg is as high as 68%. So in the waterfall plot, as we can see on the right side, most of these patients are in the green, which means that they have some kind of response as well. So as of now, there are a variety of frontline phase 3 trials ongoing. And the first trial which comes into the mind, as we have already discussed, is Harmony 7, which is undergoing for the squamous cell population, in which ivonescimab is used as a monotherapy. And the second trial is Harmony 3 trial, which is Ivaneskimab along with the CT backbone here, and in which the TPS in all comer population is undertaken. And then we have a Rosetta trial in which BNT 327 is undergoing trial as well. So we have already discussed about the other immune checkpoint inhibitors and bispecific. Now we move to the ADCs. So as we move on to the ADCs, we have this generic drug table. 4 of these ADCs are already approved by the FDA. Trastuzumab deruxtecan, as we know, have been approved in the anti-HER2 population as way back in 2022, and sacituzumab tirmotecan, that is a SASI TMT, has been approved in 2025. Again, Dato-DX is approved last year itself, and TV is also approved last year. All these drugs are as such not approved right now, but probably soon in the future. So one thing that we have to keep in mind while working on the ADC is that ADC does not only work by the mechanism of a payload. It also causes an immunogenic death of the cell. And this immunogenic cell death is important mechanism of action. Along with that, we have a bystander effect as well. So once we give an ADC, it not only affects the cells in which it goes inside, but probably it affects the immunogenicity in total, as well as affecting by a bystander effect as well. So on this mechanism, we move forward to variety of trials which are ongoing in the ADCs landscape. So we have EVOKE trial, Tropion-02 trial, and Tropion-Lung-04 trial. And probably if you look at all these trials, we find that EVOKE-02 trial is a Saki povetacicept trial along with immunotherapy, Dato-DX along with the immunotherapy, and probably also in combination with a CT backbone is also being developed. And then we have Saki TMT trials with the OptiTrop trials ongoing. The results are probably very good. The overall response rate is as high as 77% with a TL02 trial, and the OptiTrop Lung-01 trial also has 78% response rate. In comparison, we find the immunotherapy only trial, the response rate is in the range of around 50% itself. So this slide again discuss about all the trials which are ongoing. So Tropion-Lung-01 is a trial in which Dato-DX is combined with the immunotherapy in the population of PD-L1 more than 50%. Dato-DX is again studied in the Tropion-Lung-010 trial, and which again the Dato-DX is again combined with an interestingly rilvegostomig. Rilvegostomig, as we have discussed earlier, is also being studied. SAC govitecan is again being studied in the EVOKE-03 trial. SAC TMT is being studied in the TroFuse trial. Tropion-Lung-07 and TroFuse-03 are the other 2 trials which are being studied. So after finishing the ADCs, we come to our last section, that is the novel molecules, where we will discuss about variety of the novel molecules, including the mRNA vaccines, the peptide vaccines, the adoptive T-cell therapy, and the intertumoral therapies. First of all, we come to the peptide-based vaccines, which have been used and explored in the NSCLC in the earlier decade as well. The MAGE-3, the MAGE-A3 with the Magnet trial, and the other thing probably have failed. The result was negative, and we are no longer approved and using them. But one trial is still undergoing. There is Atlanta trial, in which we have this new peptide vaccine, which uses 5 tumor-associated antigens, which are frequently overexpressed in the NSCLCs, such as HER2, new CEA, MACE2, 3, and P53. They have combined all these antigens and probably prepared a vaccine which acts over them. And the result of this trial is awaited. The primary endpoint is overall survival. So why we are still using the vaccine if it has already failed? So probably we have moved on from a DNA-based vaccine to an RNA-based vaccines. In the RNA-based vaccines, it is superior in terms of the delivery of the antigens, and there are no oncogenic concerns as well. And in this phase only, we have one vaccine which is undergoing trial again, that is leucomenet 1, and it again has peptides against MAGE-A4, MAGE-C1, PRAM, CDLK, and KKLC1 is also undergoing trial. And as we can see here in some of the patient population, it is showing a prolonged and substantial response. Probably these are the some subgroup of the patient in which these peptide vaccines can work better. So if you look at this subset, we find that in the patient population whose PDL1 TPS is less than 50% also, at least half of the patient have shown at least a partial response. Some patients do have a very good partial response as well. The overall response rate in this population is around 45%. The overall PFS is around 9.9 months. And then we come to our final part, that is adoptive cell therapies in the form of a TILs, a CAR T cell therapy, and a TCR T cell therapy. So among that, we know the mechanism of action of probably of all these things. So we'll move on to the TILs. So TILs is used in the population which is PDL1 refractory. So in this population, in this trial itself, this is a phase 2 trial, which we are discussing right now. So we have used nivolumab for 4 cycles every 2 weekly, and those patients who have progressed on nivolumab are infused with a TIL which has been elected before the starting of the immunotherapy itself. So as we can see on the right side on the forest chart, we can see that there are probably some patients which have responded beautifully in this chart. So on this waterfall, there are 2-3 patients which are ongoing trial and probably will have a substantial and continued response as well. Second therapy which is being developed is alifileucel, which is an autologous monotherapy, which is already approved in the melanoma. This response rate is probably good in the NSCLC population as well. The overall response rate is around 21.4% in this subset. The OS is not reached right now, but as we have seen in the last slide as well, there are some patient and population in which it has responded very beautifully. So we have to probably look into this subset of the population. Then finally, we have cytokine-induced therapy. We have CIK therapies. The rationale is that there is a mixed population of the immune effector cells which are not collected from the PMBC, which have cytotoxic cells, potential to kill the cells which are PDL1 negative. So by this rationale, we have started using a CIK administration, which can be used as a single agent or can be combined with the immunotherapy or a chemotherapy backbone. As we find in this trial, which was published last year in ESMO Asia, we find that this kind of therapy do have some benefit. At least in this trial, this has been a substantial benefit. The hazard ratio is around 0.35 with a PFS of around 19.1 months versus 9.2 months. The overall survival is also superiorly increased. The overall response rate is magnificent in the terms of 80%. So probably we will have some future of such therapies in the upcoming future. So for our final thing, we have CAR T cell therapy, and this was published in the ASCO 2025. This was for the SCLC, but similar CAR T cell trial was also published for the NSCLC as well. We have some mixed response in the terms of CAR T cell therapy. So we have response rate in the tune of 67% in the terms of a disease control rate. For some patient, they have responded pretty well, but for most of the other patient, the response is not as good probably. So probably CAR T cell therapy in the lung cancer is something which is still in the development and probably will take some time to come into the future and picture. So this is my last slide. It tells about all the important drugs and trials which is ongoing in the phase 3 right now. Most of this we have already discussed. Ivonescimab, BNT327, we have discussed. Datu-DX, sacituzumab, TMT, volrustomig, rilvegostomig, and relatimab. All these things are in the pictures. Please, we will be waiting with a lot of enthusiasm for these results to come. Thank you.
Thank you, sir. Thank you for the very informative presentation. Now we would like to move on to our next session. I would like to invite Dr. Sunil Jaiswal, Senior Consultant Surgical Oncology, Bhubaneswar, on the topic robotics versus VATS. Over to you, sir.
Hi, good evening, everyone. So, I'll be talking in favor of robotic assisted thoracoscopic surgery. That said, a well trained surgeon can get the job done either with a robot or VATS. But robots have some advantages. Next slide, please. So, the key differences with robot is we get a very superior vision, which helps us to get the job done easier. There is enhanced dexterity because of end-of-wrist movement, 360-degree movements that we have with the new system. There is also tremor filtration, which also helps in the surgery during robotics. And there is improved ergonomics with robotics. We are in a sitting posture in comfortable position. During long procedures, we usually have better ergonomics with robotics. Robotics also shines in complex cases. If we compare it with VATs, robots makes it easier to get the job done. Next slide, please. So there have been also differences in outcomes based on evidence. There is less blood loss as compared to VATs. There is less chances of we converting it to open surgery when we are using robotics. And there have been a debatable question that there may be higher lymph node removal associated with robotic surgery. And there is also reduced post-operative pain associated with robotics. So all things said, robotics really helps us to give better outcomes and helps us a lot in complex cases that we do thoracoscopically. Thank you. Next slide, please. Thank you. So we can move it with Dr. Sashi's part.
Yeah, sure, sir.
Hi,
Now I'd
can
like
I
to
share
welcome
my
Dr. Shashi Shetty, Senior Consultant Surgical Oncologist, Fortis Hospital, Vashi. Over to you, sir.
can I share my slide?
Yes, sir, please.
I can't. How do I share it?
The access has been given, sir. You can directly share your screen and select your slides, sir.
Uh-huh. So I can directly open the keynote. Hello? Hello?
Yes, sir.
Hello?
Yes, sir. Your slides are not visible yet, sir.
Hold on. Before we get the slides in order,
Um, so should we share the slides from our end, sir? Is it okay?
you can do that, but I'm unable to see the.
Yeah, requesting the technical team to share sir's presentation, please. I hope it is visible, sir.
Mhm. 1 minute, please.
Yes, sure, sir.
Yeah, can I go to the first slide? Hello,
Yes, sir. It's visible.
can I go to the first slide?
I hope the screen is visible, sir.
Yes, yes, yes,
Okay.
yes. Okay. So, VATS, I'm Professor Dr. Shishir Shetty, and my colleague is a very good robotic surgeon. If you look we got delayed because most of the time the robot takes a lot of time to get, to docking time and stuff. But let me tell you something that before the robot came, we have been doing VATS, and we have 30 plus years of the global experience. And it is a standard of care in most countries. Millions of cases worldwide has been done. And the best part is I can do a VATS in anywhere. So I don't really need a great setup to do a VATS. I have to have a good anesthetist, but it is a reproducible technique. Can I go to the next slide? Hello? Yeah. Now, if you look at the surgical outcomes when it comes to VATS or whether it comes to RATS, that is robotic assisted thoracic surgery, there is no randomized trial which shows that robotic surgery is oncologically superior. In fact, meta-analyses have shown equivalence. And outcome actually depends more on the surgeon rather than what platform they are using. So the surgeon is very important. If you've got a good trained surgeon, then I'm sure that even VATS or robotic, he'll do an equally good job. But if the surgeon is not experienced, and all those things about getting extra lymph node, getting great margins are all bogus. Next slide. Now, if you look at the outcomes, perioperative outcomes, I feel the anesthesia time in VATS is very less compared to RATs. But in any way, blood loss, air leak, length of stay is all same. Now, people talk about conversion rates. Conversion rates from a minimal access surgery to open surgery is always dependent upon the surgeon. So we cannot say that just because it is robotic or VATS, conversion rates are high. Next slide. The only biggest problem that we face, especially in our country, is the cost. The cost is prohibitively high. A Da Vinci XI system would put you by not less than 15, 16, or 20 crores. Annual maintenance itself comes to more than a crore. Whereas VATS is affordable. We already have got laparoscopy system across the country in every village possible. All you need is a few more instruments and you're all set for VATS. All you need is a good anesthetist and you can do this procedure anywhere. In fact, no outcome, even if there was, I don't think there is, can benefit just to justify cost. Next slide. In our country, the problem is the lack of robots and the lack of trained surgeons who can do lungs. I can count in my finger how many robotic surgeons are available who can do this. Next slide. The only biggest problem that we face today is that the learning curve. Robotics does take a long learning curve. It is more of independent institution is dependent. Not many institutions have it. The majority of the surgeon don't get to train on it and they don't have experience. VATS is more or less standardized. You need a good anatomy and it is teachable. I can share knowledge very fast and it's ideal for training programs. Next slide. Now, robotic, the biggest problem is the docking time. The docking time increases the OT time and the anesthesia time. And believe me that it is, if there is an emergency, robotic to convert to open can be a task, whereas VATS, it's very easily available. And there is no tactile feedback in a robot. Next. I can go on and go on about how VATS is more superior. If you look at guidelines, I think most of the guidelines would accept both the procedure. The important thing is minimal invasive surgery. The minimal invasive surgery is superior to open surgery. VATS remains the benchmark for minimal surgery approach. Next slide. Conclusion, there is equivalent cancer outcomes, lower cost, greater access, proven reproducibility, and VATS is the most practical and responsible choice, especially in our country. Thank you.
Thank you, sir. Thanks a lot for sharing your perspectives on VATS. With this, we are concluding the sessions for the day. As we conclude, we extend the heartfelt thanks to our esteemed faculty who has joined today and sharing their valuable time and expertise with us. And a special note of gratitude once again to Dr. Suman Gupta for his leadership as a program director, and to IAIO for continuously creating and being a part of IAIO for creating this impactful academic platforms. I would like to thank all the participants for being a part of this enriching session. So we look forward to welcoming you all at future IAIO Expert Insight programs as well. Thank you all.
Thank you.
Thanks a lot. It was lovely.
Thank you.